pleasure to be here today. My topic today is a much less technical one than some of the others you've had this morning. I'm just going to talk about some of the issues and aspects of integrating the specialties of radiology and pathology and how that can contribute to improved cancer diagnosis and care planning for our patients. I'm a consultant radiologist now at Galvin Hospital in Northern Ireland. I've been involved with the NIPACS project and now the NIPACS service in Northern Ireland since its inception, even before its inception. And I'm currently working as a part-time consultant radiologist, but I also work with Sectra as a senior clinical advisor to UK. So in this presentation, I'm hoping to look at some of the similarities and the differences and the parallels between pathology and radiology and the contribution that both specialties make to diagnosis and care delivery. We'll also look a little bit at the history of how we've handled our images and our reports and how we've shared them. I look at the pressures that exist and have existed and continue to change in how we deliver service and the constant pressure on us to improve our efficiency and our outputs and our impact. And the basic message is that sharing is caring. So first of all, let's remind ourselves what we're involved in, what business we're in, and healthcare is largely a data handling exercise. In between times, we occasionally do little bits of medical action and intervention, but mostly we're capturing data, manipulating it, storing it, sharing it with other folks, taking it out again, reviewing it, manipulating it some more, storing it again, and so it goes round in circles. But no matter who we are or what we are in healthcare, most of what we all do is very, very similar, and only a really small part of what we each do is truly unique. But unfortunately, when you're trying to implement change, sometimes that word unique really means special or very precious or perhaps even elite. So pathology and radiology, we're both opinion-based specialties. So people often say the most important words in a radiology report is which radiologist's name is at the bottom of the report. And that's a very meaningful statement because it tells you something about the intrinsic character of a radiology report. It's based on an opinion. An opinion is something that's very hard to quantify. It's based on knowledge, expertise, experience, track record, confidence levels, familiarity, all of those things. So whether we're a pathologist or a radiologist, the evaluations we make are heavily based on the clinical context. So the old phrase is garbage in, garbage out, and that certainly does apply here. And we're all very much aware in radiology as to how proper clinical information does influence how we form our report. So what we're really looking for is the situation where we have the fully informed reporter producing the fully informed report. And after all, the report is our final output. Now, we're very familiar in radiology with the problems we had for years handling physical media and paper requests and reports, and partly that still applies in pathology. We've all got the pressure to do more with less, and we, just like our pathologist colleagues, are struggling with the challenges of subspecialization. Now, there are, of course, differences in pathology and radiology. If you go and visit a pathology department, you will be amazed how quiet it is. The corridors are not cluttered with these patients. They don't have inpatient pressures. It's a totally different departmental ambience. We've got bed managers, head injuries, not so nice guidelines, on-call issues, direct patient contact. So we're quite different in some ways, but the final analysis of what we do is very similar. So what are the contributions that our specialties make? We're both key service specialties, and the reports we produce are critical for getting the right diagnosis for many of our patients and for making sure that the correct treatment plan is formulated. When you're at an MDT, you will be very aware that the key participants in terms of the diagnosis and treatment planning are often pathologists and radiologists, and their inputs often change what might have been the plan beforehand. We're both frequent users of informal second opinions with our colleagues and formal second opinions, particularly in the era of subspecialization that we are now in. And we've both specialties, we've got staff recruitment and retention issues. So if we look at the key elements to what we do to ensure that the correct diagnosis is achieved and the correct treatment plan applied, there are many steps to it. And much of what we do is absolutely hidden to outside viewers. They're not aware of the work that goes into vetting, modifying requests and studies, setting the protocols for imaging and tissue processing, all the work that goes on in monitoring image quality, examination quality, slide quality. There are issues associated with the physical environment within which we do our work, the lighting, the sound, the ventilation, the temperature, the ergonomics, the interruptions. We're all aware of how these impact on our work. In terms of the actual system that we're using to view the diagnostic material, image display quality is vitally important, but it's more than just image quality. It's how the images are displayed, how the system supports and facilitates what we're actually trying to do. And the challenge is really for us to optimize the act of diagnosis and to minimize the mechanics of the reporting process so that we can really concentrate on the key activity, and that is the key activity of making a diagnosis. Part of this support means having prior images and proper analytical tools, added value software. We also want to be involved in messaging to our colleagues for second opinions. I do recall with great joy the first time I got a message from a remote colleague 80 miles away while I was sitting at my desktop asking me to review a study that had been done in a remote hospital in a different trust. And in a moment or two I was able to review it and interact with them, send a message. And it was just so enjoyable to be able to work at that level compared to what we were doing beforehand in the era of cut film. Also, we want connections to other clinicians, tertiary level opinions as well. And these days, multidisciplinary team meetings, which we'll talk about later, are very important. So if we can have easy preparation for these and meaningful participation in the MDT process, then we're really contributing to good patient care. So what would be the benefits of integrating pathology and radiology rather more than we have at the moment? Well, we want to be connected to our own specialty colleagues, but other specialty colleagues as well, clinicians and the web. Fundamentally, we're looking for better informed and connected reporters. We want this correlation between the macro environment that we see in imaging and the micro context that we see in pathology. We're used to it in radiology, easy key image and reference image tagging, but we want to offer that same easy facility to our pathology colleagues. Prefetching of prior studies and access to these key images is a real marker for improved quality in the reviewing and reporting process. Synchronous and asynchronous messaging is very important, and there are opportunities for new work practices, perhaps for our pathology colleagues. And obviously, we're looking for better professional relationships. We're both involved in the diagnostic process and are reminded of the fact that the farmer and the cowman apparently should be friends. So let's look at the MDT specifically. The MDT is the shop window for radiology and pathology. Because we're connected now, so the clinicians don't need to come as much to the radiology department as they used to. And in fact, I make a particular point now of welcoming and congratulating anyone who comes to see us, because it's such a pleasant interaction to have people giving you cold-faced clinical input. But the main key benefit to our patients from the multidisciplinary team meeting is the robust quality assurance of the opinions we make and the decisions we make regarding treatment plans. And the more open those discussions are, the better. Now, many of you will recall that in the early days of MDTs, pathology used to come with big bundles of slides under their arm and take great pride in showing them. But then the logistics of that and the practical difficulties of doing it meant that that became less and less common. And now most of these meetings, or many of them in many places, are limited to simply reading reports, admittedly with review of the examinations beforehand, but again, reading reports which does not allow open discussion and confrontation regarding certainty of diagnosis. We're all aware of the importance of review and looking at things and setting them in the clinical context, which might mean more clinical details, clinical progress of the patient, the radiology opinion. Are you sure it's malignant? Is it really invasive? Are these really metastases? Open discussion produces a reduced risk profile and a better possibility of getting the right treatment plan. And fundamentally, are all professional groups comfortable with the diagnosis and the way forward? Let's look at the history of data handling and sharing that we've gone through. In the old days of cut film, we had the departmental hard copy silos. When I started working as a doctor in the hospital, the radiology pictures, the films, never left the department. Tiny copies were made and they were given out to the clinicians, but if they wanted to see the x-rays, they had to come and look in the department. We then moved on to isolated department-based computer silos. You still had to go to the department to look, but it was faster. Then we had connected silos, but no complete history. You still only really got what you knew was there and what you asked for. The big vogue for central storage facilities really missed the key need that was developing for sharing and post hoc review of stored images. Now we have standards-based vendor-neutral archives, and the key thing is in networked, dispersed care models, as we saw in the last talk, we need enterprise-wide data continuum with data transparency. And in a connected system, we hope that the data deficits are reduced, although there's always still the human element involved there, but they're more easily rectified if we notice them. So it's no longer acceptable to work in splendid isolation. Climate change affects more than just the Arctic, and things are definitely hotting up for all of us. Some folks are blissfully aware or unaware of the reality of their situation. But there are a lot of folks who are just longing for human contact with other clinicians, other professionals. But the challenge of bridging the gaps, we've seen the challenge in the previous talk, the challenge of bridging the data and communication gaps can be very daunting indeed, if not dangerous. And to be frank, some people just give up. So we hope we're not here today to give up. We're here today because we're interested in doing something better. And any of us who have been involved in regional or super-regional multidisciplinary teams over the years will know that sharing and transferring of physical media can cause and has caused conflicts and disagreements. And it would be so much better if we were all just one big happy data sharing family. Otherwise, we might get left behind, and you can see how recruitment and retention might be difficult in this kind of a situation. So, what about these service delivery changes and pressures that have been ongoing for the last decade or so? Dispersed network care is a really good idea, but it mustn't mean fragmentation. So every time we compartmentalize our care, we have an ever greater need for transparency of the data. At the same time, we've increasing subspecialization in all our services, and this requires and demands better communication. So once again, we need that data visibility enterprise-wide. And if we can give a connected service to our clinicians, our radiologists, our pathologists, then perhaps we will be more able to recruit and retain staff. So let's put ourselves at the center of a web of data, and we're really looking for the enterprise-wide data continuum. But it's easy for us to take a centered view on where we are. But the very existence of this meeting highlights the fact that data is the key currency that we all deal with. And we know that less transparency can give suboptimal outcomes. One of the big changes that we have noticed with risk packs is that it's not just for radiologists and radiographers. It has a simply huge impact on everyone's work. I was giving a talk on the NIPACS project in Belfast recently, and afterwards somebody came up to me and said that the NIPAC service had revolutionized their clinical work. And I said, and where do you work? And she was a community dentist. And I didn't think we were having that big an impact, but she said it had just revolutionized her work because she had instant access to data to allow her to do her work. So the impact is very, very extensive. But it's easy to take this old-fashioned centric view. The report is our main output. Nobody comes to see us anyway. We are a remote diagnostic service. We don't need to share our data. And many pathologists perhaps still feel in this way. But the patient and the enterprise-wide view is rather different. The patient would say, my data and my images must be available where and when they are needed for my care. The system will be aware that review and discussion gives better quality assurance of opinions and treatments. The patient would say, I would really like full multi-professional discussion of my diagnosis before I get treated. The system knows that multidisciplinary teams are multimodality, multi-site, multi-provider, so they're complex beasts which need IT support. And the managers know that connected services can allow support for services that are in crisis. And that's really important these days when we have recruitment issues. So the wider view is more helpful to patients and to the service in general, and it's more reality-based. So nobody in radiology would like to go back to the days of multiple simultaneous demands for access to the data, and we don't miss the perpetual fight for the celluloid. So let's make sure everyone else in our health service has the same benefits. So the big picture really is that your RIS-PACS infrastructure is a resource for all image producers. And that robust handling and storage that you enjoy for your radiology images should be available to everyone. Now, there are issues associated with that. It's not a takeover bid. It doesn't mean that radiology wants to manage everybody else's life and tell them what to do and push them around. It's not taking on management responsibility. It's simply an efficient use of expensive infrastructure that is often already there for the benefit of our patients. And if we can give our clinicians a single portal for viewing all their images and reports, then we will energize and make more efficient their work. And in particular, with relevance to pathology, a digital connected pathology service would energize our links to radiology, improve our relationships with our pathologists. And remember that a single platform for all our medical images would be MDT heaven and improve our discussions. So basically, I want us to think of a data continuum, a web connecting people, places, institutions, and services, and hopefully there won't be too many gaps in that. Thank you for your attention. Thank you.
Any questions from the floor? In NIPACS, you use a single database and you use a single number. Do you connect every single hospital on that, or do you have issues between any hospitals you don't include?
It's a little bit complicated. We connect every hospital in Northern Ireland and every trust in Northern Ireland, but not quite every department, because unfortunately the dreaded PFI got its claws into some of our bigger trusts, and the PFI contracts were set prior to NIPACS. So basically we are Northern Ireland wide with NIPACS, so every trust has NIPACS. Every trust has access to NIPACS. In fact, there are many departments within trusts which are PFI contracts for other aspects of RIS-PACS, and we're there as well because they didn't consider the need to sort out the smaller departments. So we sort out all the departments that want us. And unfortunately, the PFI cancer goes very deep and is very hard to eradicate. Even radiotherapy won't eradicate it. It's too legal for that, unfortunately.
And you're now extending into pathology, and is that because you feel that it's easier to have the data as one MDT, or is it because you have the same issues in pathology that radiology has, and outsourcing and so forth?
Well, I think there are a couple of issues here. Fundamentally, if you've got a big RIS-PACS infrastructure, it's sitting there begging to store all the images. Because the way we store images at the moment for all the other ologies can be reasonably good, but it can be woefully inadequate, and often is. And the previous speaker talked about the difficulty of, even when you go to try to sort things out a little bit, you find that there's complete chaos and mayhem, and therefore you need to have solutions which sort out the little guy who makes a few images a month, and the big guy like cardiology who produces thousands and thousands and thousands. So you need solutions that work at the low level and the high level. But the infrastructure is there, the robust sharing and storage is there. It's a question of us making sure that it applies everywhere. So in my simple analysis is that all medical images deserve the same robust standards of sharing and storage. And in radiology, none of us would go back to viewing hard copy images. So if digital imaging is good, and it is good, we saw Pontus showed us slides this morning of pathology. The quality of the pathology viewing is fantastic. The ability to store the key image that shows the diagnosis and prior image analysis, all of those benefits that we have in radiology should be available to our pathologists as well. It's a different game for them, and they perhaps are not familiar with it or don't see the need for it. It's easy for us in radiology to see the need because we are so acutely close to acute patient care. and clinician involvement. But I think when we think of the pathologist being better informed at the time of making their diagnosis, better involved and able to participate better in full discussion of cases, and to be connected to clinical colleagues to be able to rectify data deficits, etc., the benefits are there. It seems silly not to move that way.
I thought that talk was fantastic, and I'm very much trying to follow a similar vein in my trust with the help of Nick and the SWASH Consortium. And to me, that your viewpoint is a no-brainer. What resistance have you come against? You know, there are surely people who don't agree with you, or does everybody agree with this vision that you've got?
Sometimes it's difficult for people to see how bad things are. And when things are really bad and have been bad for decades, it's easy for people to think that this is normal. I mean, the two ladies who were sitting on the ice floe seemed reasonably happy. But they shouldn't have been, really. So I think often it's a question of illustrating to people how it could be better. And at the end of the day, my view is that patients deserve the very best management of their images that is available to us. And hard copy storage is not acceptable anymore. It's dodgy, it's unreliable, it's dangerous, it's not shareable, it's not viewable. It doesn't meet any of the standards that need to be applied to a medical image. So therefore, we should be moving forward.
I just wanted to ask a couple of very practical things that I don't completely understand. From at the level of the histopathologist with his glass slides, I mean, for us in imaging, it's easy in a way in that the radiographer takes the images and acquires them, and the entire study goes onto our packs, and we have no say over it particularly. We could ask for more views to be done or whatever, or reconstructions to be sent and that sort of thing, but that's modifying those data that are already acquired digitally. So for the histopathologist, I am presuming, I don't know if you have this up and running in any trust, but are they looking at their glass slides and then deciding which snapshots they want to capture on a digital microscope? I mean, how is the actual original data acquired? Because they may actually choose, you know, the wrong, I say the wrong, they may omit to keep a digital copy of an area on the glass slide that is actually turns out to be very relevant. Or how is it acquired? What system are you using to acquire the data initially, if you see what I mean?
I think there have been other talks at the meeting that have gone into this in great detail, but basically it's a systemized process that processes the material. So essentially it's a bit like radiology, where you determine with your radiographers what MR sequences are done for brain and for MRCP and for MSK, all of that. So the stains that are to be done, all of those things are set up by the pathologists. And then the slides are scanned. The slides are produced as usual and then scanned automatically into automated systems. Okay. So they're then available. But I think the key thing is that in that morass of data that is then produced, the pathologist is able to drill into it and store the relevant key images and share them with their colleagues, energize the second opinion process, the consent. Pathologists love consensus opinion reporting.
Yes.
So there are opportunities. The multi-header, I don't know if you're aware of this term, the multi-header review sessions that pathologists do, those could be changed and be done electronically in many situations, etc. If you need a higher level, third level opinion of pathology, the delays in transmitting physical media.
No,
and
absolutely, no, that fully answers what I wanted to know.
So a lot of the things that we talked about earlier in terms of improving the reporting environment for radiologists similarly applies to pathologists, and the digital environment can enhance that as well.
Okay, thank you. Then I just had one other sort of practical query, and that is, as a radiologist, you're not going to want to see stacks of pathology in your unreported work list. So what system is being used to sort of, are you having segregated archives here, or how are you actually getting all that unreported pathology out of your vision when you're just working through your normal work?
Well, I mean, it's quite easy to segregate work lists, etc., so you're not trapping over medical photography images.
So you're just making your own work lists effectively.
Yes.
And would you know, presumably in the patient jacket or however the PACS is arranged in terms of its software, it would be easy for you to see whether there was associated pathology, I take it? Do you see what I mean? So I've reported my, whatever it is, my follow-up of the HCC of the liver, hepatocellular carcinoma, and I want to know what the histology was, or to know indeed whether there was histopathology ever acquired. How would I sort of physically do that? It would be I'd go into the patient jacket, or there would be some kind of means of seeing that, would there? As a radiologist, I mean.
As a radiologist, we don't actually have this at the moment, but I'm sure that that is the idea, that we would be able to have a window into other relevant sets of information. And it's a question of setting up your work list so that you are aware of them, etc.
Yeah.
Digital pathology is a new kid on the block here, and how it works is being explored and looked at. But I think the opportunity that it offers pathologists and radiologists to interact better is the key thing. How we construct it and make it work is largely up to ourselves, but the ability to do that is not, it's not unreal. It is a real.
Yeah, yeah.
Scandinavia is
Yeah.
much ahead of us
Yes,
in this
they
regard
are.
at the moment.
Yeah,
Okay.
thank you.
May I ask, you've managed to get an identifier for every patient to work. How did you do that, and how do you manage it?
Well, it's one of the really great things that allowed us to do what we have done in Northern Ireland. Someone a long time ago thought that they should have a single identifier. It was called the UPCI, the Unique Patient Client Identifier. We have health and social care integration in Northern Ireland, so that was why it's called the Unique Patient Client Identifier. It wasn't meant to be an acute, cold-face, real-time supporter of healthcare delivery, but over the years, with the NIPAC's vision, it kind of morphed into the real-time identifier. Now, we had hundreds of numbering systems in Northern Ireland, as you all have still, and I was petrified, to be frank, when we were putting in the NIPAC's project, that it would not actually work and that the clinicians would just object to using the healthcare number. But the uptake of it was just almost painless. The clinicians moved into it with ease. And part of that is that we anticipated problems, so we had a mapping system. If you put in the old number, you'll get the health and care number. If you put in the health and care number, you can get the other numbers as well. So we supported that in advance. But basically, everyone in Northern Ireland now uses the health and care number. No one uses all these other ridiculous numbers that we've had for decades.
It's interesting that Scotland has exactly the same scenario and are able to do the sharing throughout Scotland because of exactly that vision that we haven't managed in the UK yet. Great. Thank you very much. Great. So.